Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. First of all, it's my pleasure to be here today. Thank you, Hani. Thank you, Muhammad. All the scientific and organizing committee. It's a pleasure to be with you in this conference. So my presentation today seemed to be something good and bad, but that's why I put the red. So the complication always usually have to be considered and have to be treated. So my talk today and tasks is very difficult to cover all the topics, but I will concentrate mainly on POM, but I have to mention some of the other third space complications. So the complications usually need to be managed. So this is, I don't have any conflict of interest related to the lectures. So this is the objectives. Mainly, we have to have at least encounter all the complications and you have to know about the complication. Number two, before it's happened, you have to prevent it. There are a lot of ways and method and preparations easy to prevent the complications. If it's happened, then you have to treat it and you have to recognize it first and don't leave it. There are some common complications. I'll talk about them today. And also I will touch mainly on GERD. I know it's a huge topic, but little or maybe a few slides about GERD. And then I will end my presentation by the summary. Achalasia, I will not expand more. This is a fact. Now is the commonest motility disorder. Number two, and also the endoscopic management is the main and also gold standard. POM became one of the gold standards treating all type of the achalasia. I know there is also other modalities, endoscopic modalizations or surgical, but this is one of the procedure now. So it's almost worldwide and accepted by all the endoscopists. Very effective and safe. Complication can happen. Okay. Before you start, you have to inform your team about the preparations. Okay. You have to prepare the patients. You have to prepare yourself. You have to have the CO2. And we have to have some of the measures before you start your patient or to start the procedure. Keep him in BO longer. You start to anti-emetic, PBI, and also using some of the scopes with good and large worker channel. CO2 is the must, and you have to be aware about your setting or electrosurgical setting. To control hemostasis, very important to have all the method. Co-grasper, clips, and other over-stitched device to control the bleeding. Now, this is the setting. So you have to be aware about the coagulations. Sometimes it's very important to know what's the difference between the precise cut and spray coag, soft coag, or maybe force coag. Help you preventing the damage to the mucosa or maybe controlling the hemostasis. Now, this is the complications. It became less and less. As you see, this is very landscape. Good adverse effect of with good number of patients, as you see, is almost the total number of the complications almost is 8.2%, and most of the complications are minor, so it's not a major complication. But the important things of this study, as you see here, there is no mortality, zero mortality for this procedure, and also if you see the major complications, almost 2%, and some of the reported in the studies almost 1.2%. So minor complication can be treated. As you see, this is another study showing that the severe procedure-related effect is almost 1.2. So still is acceptable, and also it's compared to other procedures. So can be treated, yes. And there is no inpatient mortality regarding the procedure or third space. If you consider GPOM and ZPOM is almost the same and similar. You see, there is a lot of meta-analysis here showing that the adverse effects almost from the 8%, from 6 to 11. If you have the ZPOM, it's almost the same. They have from 0 to 13%, is also 6%. So if you can take all the third space complications around 6% and 8% and major, or the most of those complications are minor. Now, this is the commonest. This is almost 10 years ago. They have CO2 retention is the main, and also they have the mucosal injury and with some intestinal exposure as the commonest. Now, taking this study is published by Mohan Group and also Zahir from Hyderabad, is one of the important studies to classify the complications. As you see here, they consider the pre-procedure intra-procedure and post-procedure, and on the same time is anesthesia related, and they have a separation of the mucosal injury depending on the thermal injury or maybe mechanical injury. This is very good study to be you have to have spending time to review it and to apply it to your patients. There are also some factors that can affect the complication. If you encounter patients redo surgical or POM, or maybe patient would have some mucosal fibrosis or sigmoid esophagus, and those patients usually they have to have high risk of complications, so you have to be ready. As you see, this is one of our patients. So once the patient is intubated, he get aspirated. So you have to make sure about patient fasting for longer than 2 days, 3 days. Sometimes you have to keep him liquid diet longer than 3 days or 4 days. So this patient was, once you intubated, the patient really vomited and aspirated, as you see. So how you to prevent it? Some of the experts, they have to scope the patient with a conscious sedations before the general anesthesia to prevent this complication. So you have to consider managing those patients in ICU, or you have to give the patient IV antibiotics. So this patient is staying in a hospital a week and then he recovered. Number 2, if you have a CO2 retention, this is one of the important things. You have to decompress the patient if you have some of the hemodynamically unstable. But before that, you have to use the low CO2 flow, and then see, this is the one important to insert, and you can insert the needle, the second needle, to decompress. So you can hold the procedure. If the anesthesia told you have to stop, you have to stop, okay? And then you have to temporarily stopping the procedure is safer. Once you decompress your patient and then patient more stable, then you can complete the procedure. Or maybe you can shift to the saline without CO2 or air. So this is eliminating all the CO2 retention. Taking back the scope out, go to the stomach, suction all the air or CO2 also can help. And at the same time, needle is very important, and now is popular if you have some of the CO2 retention is high, or the setting is almost the anesthesia tell you have to have maneuver to decrease the CO2. This is one of the maneuvers. So the most important complications, the mucosal injury. As you see here, they have clearly divided the two groups of the mucosal injury, either mechanical or thermal. But as you see, this is all our patients. So if you have this patient, this is almost Canada. You cannot perform with unhealthy mucosa. And this patient also, they have a lot of foods. Whatever you do, if you clean the patient, never to have a good and safe procedure. So you have to have very clean mucosa. These factors, it can affect the complication, or maybe common happen with those factors. If you have a patient having unhealthy mucosa, infections or stasis, esophagitis, if you have a less injection, if you have a submucosal, or once you start dissect, you counter fibrosis, usually they have some of the mucosal injury, or maybe at the beginning of your procedure. So the learning curve getting some of the endoscopy is very quick, but usually at the beginning of the of doing this procedure, usually you counter this complications. As you see here, how to prevent it, how to manage it, you have to inject a lot, and you have to have some of the irrigation of saline, and then you have to stay away from the mucosa. You have to be in the muscle sides. So down, you have to be very precise. And number 2, the setting is very important. Most of us, they use spray. Spray coag is very good, but it's very dangerous to mucosa if you have close to the mucosa. So breast size give you a good control, but you have to have a low or evolved for breast size for your spray. But in the same times, you have to use what you prefer. Now, as you see the difference. This is very healthy. This is very healthy. This is unhealthy mucosa. So better to be away. Or if you want to perform this procedure, you have to have very clean and healthy mucosa to avoid those complications. As you see, this is one of a good report. So the major is almost 1.7%, and the minor mucosal injury is almost 17%. So most of the minor mucosal injury can be treated endoscopically and can be treated by a closure. And the major, you can close it endoscopically, but you have to consider keeping the patient longer, fasting, and you have to use antibiotics. As you see, these factors usually almost help you to predict the complication. Patient with the previous procedure, hilar myotomy or POEM, those of having the fibrosis. If you have clear mucosal edema, or maybe you have a long tunnel if you perform the procedure for their type 3 achalasia. As you see, the cap also sometimes is dangerous. So if you have a very big cap, as you see in those patients, we try to enter the entry here, but we try to damage the side of the entry, causing bleeding and very extend the entry or the mucosa. So good to have a very small taper cap. As you see, now we shift to the other taper cap. Is easy now into the mucosa. Injection very easy to inject, and then avoiding this mucosa. The other patient also, we try to force, and then we have a mucosal damage at the end, at the alias, and usually this is the common side of the mucosa and very difficult to manage. So it's happened with the forcing the large cap, then have a mucosal injury at the end. We have to close the defect first, and then to either to perform the procedure, or maybe you can postpone the procedure. This also happened for G-palm, and this is almost easy to be managed. So was clipped from insides, and then to clip from outside is not that needed. So technique was published. My colleague Ahmed Madkour, I think, is when 3 and 5 patient was published in endoscopy. So good to consider clipping the patient from inside the tunnel. Bleeding is very important. We have intra-procedural bleeding, either immediate bleeding or delay, usually around 2%. So the most important in controlling the bleeding, you have to dissect the vessels, and you have to very clear to coagulate the vessels. Before, at the beginning of the procedure, we're using the co-grasper, but now with the good coagulations method, you can use spray coag and controlling or precise sec to have a good homeostasis, and you will not need to use the co-grasper most of the time. So, but this is a good to have the large vessels. Just at the beginner, large vessels, you use the co-grasper. If you have a small vessels, it's easy to control by the needle. As you see, this is one of the tricks. So you have to have a injection, a lot of saline, use the pressure and tamponade by the cap, identify the source of the bleeding, and then it's easy, once you see the spots of the bleeding, it's very easy to you can target by the co-grasper, and then it's easy to be controlled. So this is some of the key to have your tunnel is clean. So you have to control any spot of the bleeding, even the minor bleeding, you have to control it. As you see, the bleeding is very controlled. Then be careful when you start to advance the co-grasper. As you will see in this video, you can have very quick, and you can damage the mucosa because it's very hard accessory going through the channel. So co-grasper still is the main, and then different setting of the homeostasis can be used by the knife. Now, if you have some of the tricks, you have to avoid it. From the entry, you be away from the vascular entry. If you see any spot of bleeding at the edge of incision, or maybe mucosal, intramucosal, or maybe at the myotony, please control it. Use knife or co-grasper and pressure cap or saline. As you see, here's also delay bleeding can happen. So important to discover those patients if you have a drop in hemoglobin, and also you may be required to do an imaging, CT scan, and then transfusion, very important. You have to consider open the entry and evacuate all the bleeding, and then you can control it again. If not severe, you can go and consult your colleague, either interventional radiologist or surgery. Now, the leak is very important. The closure is very important. The most difficult is the entry, and the most important is the closure. You have to have very good closure at the end of the procedure and make sure it's very close. As you see this patient, so we have some of the leak happen after the procedure, so you have to go again, and you have to do the esophagogram, and the clinically sometimes they have fever, abdominal pain, leukocytosis, do CT scan, and then consider to reclose it again. If not, and then you have to watch the patient if they have any abscess or collection, then you can call AR or thoracic surgeon. Now, there are some of the rare complications. This is one of the happened in pneumothorax. The CO2 was off and air was on. It can happen, so you have to make sure about that. And then GERD, I think, this is one of the complications. I will not talk about in details, and mainly a lot of percentage. It can happen 40% and 30%, but with the follow-up, usually GERD is less. But there are two techniques here. But you see, this is one of the Japanese also multi-center cohort study. They show us the severe GERD on almost 7%. It's not. It's still they have an issue with the GERD. So how to prevent it? You have to preserve the sling fiber. And I know it's difficult sometimes, technically, but you have to try to use it. And it happened with all patients, lung myotomy, previous treatment, and also advanced disease like sigmoid esophagus. And POEM-F is one of the procedure to perform, but I think still you cannot predict your patients. That's why this procedure need time and need a lot of evidence to be implemented. So we didn't practice it. I think it's very complication and it will add a longer procedure. So GERD is still an issue, but it can be managed by BPI and other endoscopic like TIF or maybe GERDX or other simple endoscopic procedure. So recurrent of the symptoms or failed dysphagia, usually this is an issue. And what are the reasons? First, you have to make sure you have at least 1 or 2 centimeters below the ileus. As you see, seeing these telangiectasic gastric, this is one of the signs. But usually it can happen even if you have a good myotomy. But this is the differential diagnosis if you have a patient who have a dysphagia. Either the most important incomplete myotomy if it's less than 3 and 6 months. If it's more than 1 and 2 years, it's not related to the myotomy, most likely related to something else. So you consider the blown out myotomy or the functional, or maybe some of the scarring happened after your procedure. And those patients, you have to treat them either by redo or balloon. As you see here, the redo is almost 76%, and balloon dilatation is almost 60% of the recurrence of dysphagia after the first point. I think this is a very complex and big topic, but I will summarize at the end of the presentation. POEM still is safe procedure. It can happen the complications around almost 8%. The measures complication usually very less, from 1.2 to 2%. You can prevent it. Easy to manage by endoscopically. And the most important, you have to inspect the tunnel before the closure, and you have to close the defect properly. And then I think this is less with expert and high volume center. So at this I have to conclude. This is my endoscopy team doing advanced endoscopy. Even my Dr.Abed Allehibi, one who was doing advanced procedure, ERCP, and third space. This is our last year or 2 years ago, our live endoscopy. And this, thank you for your attention.